Okay, welcome to this European Respiratory Society webinar on biologic therapies in children with severe asthma. I'm Jonathan Grigg. I'm going to be chairing this session. In the old days, we had only one biologic, so that was potentially quite a simple time. But now we live in a time when we have more and more biologics coming on the market and potentially biosimilars as well. So it's a really important time to review where we are and where we will be with biologic therapies for this condition. I'm very happy to have an excellent speaker, Dr. James Payton, Jimmy Payton, who is a clinical academic based in the University of Glasgow. He's also a consultant at the Sick Kids in Glasgow, and he's going to talk to us about his experience of real-world use of biologics for severe asthma. One housekeeping thing, please use the chat function to enter any questions that you have, and I'll try and collate those and give those to Jimmy at the end of his talk. So, Jimmy, over to you.
Thank you very much, Jonathan. Good evening, everybody. It's very exciting. This is the first time I've ever been live streamed in YouTube, so it's a new experience. If I can have the next slide. I haven't got control of them yet. So I have no conflicts of interest to declare. And this is what I thought we would cover. I'm going to think a bit first about severe asthma in children and how we're generally approaching it. Then think about biological therapies and then give you some clinical data in children and then think what's available, and I'll give you what I think I've learned so far about it and where we might be going. I'm speaking to you in the context of being a paediatrician running a severe asthma clinic in the west of Scotland, which has probably got a draining population of about 2 million people. I keep getting referred. So I thought it would be useful just, this is our only question in it, and I thought it would be useful to orientate us about what you as the audience looked like. So it should be converted into a question which will give us some background information. So if you can fill that in now, just to show that you're all here and alert. And I think there should be a second part to the question. I don't know when that comes up, Ali.
Right after this vote.
So if you can all vote now, or maybe you are voting, maybe it's like the US of A. I don't know what I should expect, Ali. Can you tell me? So there you are. That's excellent. So yeah, I'm speaking to a group that's got quite a lot of experience, obviously, in looking after children with severe asthma, and quite a lot of experience of using biologics. And there's obviously some people who may be on the cusp of using them. So the second part of the question is, for those of you who are using biologics, which ones are you using? And again, Ali, if you could put the question up. So again, your chance to cast your vote. And I hope we get the answer soon. Can you show us the results? Excellent. That's excellent. Okay, so that orientates you as to who's all listening. So this, my experience will probably be very similar to the people that are using the maps, and it'll be interesting to see if you've got differences that you can highlight in the questions. So if we proceed, here's the ERS definition of severe asthma. It covers children and adults, and it's based on the level of medication you're using. So high dose inhaled corticosteroids or systemic oral corticosteroids for more than 50% of the previous year, with poor symptom control, frequent use of bursts or serious exacerbations, and potentially airflow limitation. Most of you, I think, will be familiar with the issues around problematic severe asthma, and they are that you need to get the basics right, first of all. So the first basic you need to consider when you see a patient with problematic severe asthma is, have you got the diagnosis of asthma correct? There's a proportion of people who make them through who don't have asthma at all. The second question that's very commonly a problem is, are the medications being used correctly and appropriately? So is the technique correct? I'd have to say, in my experience with the use of spacers, most people get a reasonable stab at the technique, but clearly adherence issues are a more problematic issue, particularly in relation to severe asthma. We have to think about comorbidities. Probably the common comorbidities I would see are things like obesity, rhinitis, and particularly psychosocial issues as a thing, and that's often given a label of asthma plus something else. And then you have to ask yourself, is the asthma controlled? Occasionally by the time a patient gets to me, actually their asthma is not too badly controlled. I think that's been particularly true during the lockdown period in the UK, when people have not been exposed to viral infections. And if they're coming to clinic after that, then often their asthma actually is quite well controlled, and we don't need to do a lot different. And then finally, we get to the group of people where all the other issues have been dealt with, and the asthma is then considered therapy resistant. This is a very good article which I would recommend to you, that's just been published recently in The Lancet. It outlines the sort of approaches that you would go through in dealing with a population of people with severe problematic asthma, and it shows you the boxes you're trying to get. So we would have not asthma, we would have difficult to treat asthma. That would be around compliance problems or some other factor where we potentially could make a difference to their control. And then you've got the group that's therapy resistant, either purely therapy resistant or they're therapy resistant, plus they've got other factors which are not immediately sortable out. So for me, that would often be psychological factors that have to be dealt with at the same time as thinking about the asthma. We've a variety of tools I'm sure you're familiar with. The asthma control test is very helpful. The ERS definition was an asthma control test of less than 20. In fact, most of the people that are coming to the asthma control, the severe asthma clinic that I run, are usually around 10 or less. We've got lung function. So here's a person who's got significant obstructive lung disease with hyperinflation. And for many of us, we will also have exhaled nitric oxide as common markers that would be available to us in the clinic. Clearly, we would have all the blood tests such as eosinophil levels and things as well. Increasingly, I think people are recognizing the investigation of medication use and routines. I think routines for me is a better term than thinking about compliance, but that it comes down to checking your inhaler device use at every visit, either online, where it's quite easy to get the parents to get the inhaler and check how things are going, or in the real world. Asking about adherence and routines. We can routinely check the GP prescription issuance, but clearly that doesn't equate to the same thing as actually dispensing the medication, although I think we're probably not too far from being able to get that as well. Occasionally, drug levels can be useful. So for the people on prednisolone, if your prednisolone level is 0, then you know it's an issue. And then increasingly, I think we have tools available to us that help us monitor routines. And we've now got a separate clinic that we send the patients to monitor their adherence. This is the Haley device and a second one. So the Haley one was the previous one, which monitors when you press the inhaler and keeps a record of it. We've taken an alternative approach, which uses an app developed in Belfast, which uses video directly observed therapy. So the patient is asked to take a little video of themselves, either by themselves or by their parents, using the medication, and we can then check that and work out whether they're taking it correctly and also whether they're taking it at the appropriate time and in the appropriate amount. And here's a patient who actually was getting that monitoring. This is one of the first ones we did. And if you look down here, she's using serotype, fluticasone, propionate, and salmeterol. And you can see that once she gets into it, she's using it at 5:50 in the morning and 17:35 at night, 6:45, 17:40, 6:30, 17:46, 6:09, 17:40. So her compliance was absolutely perfect, and it was almost to the minute. And this little girl's actually got diabetes as well. So her mother was really organized and had to be for giving her medications, and that had spilled over into her asthma medications. This girl's got severe problematic asthma, but she doesn't have an adherence problem. You'll all be familiar with the idea that asthma is not a single definition. We have a variety of recognized clinical phenotypes. So for us, maybe what people label as viral-induced wheezing or exercise-induced asthma that we would think about. And increasingly, we're being encouraged to think about endotypes, so that what is the, if you like, the molecular basis underpinning this, what's the biological mechanism that's doing that? And I think this is very important in thinking about severe asthma. You'll know that the endotype that relates to most of the drugs that we're going to talk about today is derived from adult atopic asthma, and it's a Th2 predominant disease with these sort of side effects: IL-4, IL-5 particularly, and IL-13, which act on IgE mast cells and eosinophils. So that's basically that's where we've got tools available at present. Now, most of this work's come from adults. There's much less work in children, but clearly the allergic asthma phenotype starts usually in childhood and then spills over into later life. So we're extrapolating from an allergic asthma phenotype in adults back to an allergic asthma phenotype in children just now, while we gradually fill in the research details about what's happening in pediatric asthma. I think it's very important to think about the outcomes that we're dealing with. And I think traditionally we would have been looking at these sort of outcomes. So we would have been looking in chronic asthma management to improve asthma control. Symptoms, normalizing lung function, improving the functional status, so your ability to exercise, and overall improving your quality of life. Gina, I think in the last few years has emphasized the importance of risk. Risk means the risk of asthma attacks, and with that, the associated risk of death. One of the things I got from the study in England, study in the UK looking at asthma deaths, was a sort of realization that people don't die of chronic asthma. What they die of is asthma attacks. And therefore, that's an extremely important part of thinking about asthma outcomes. So we've got chronic symptoms, if you like, versus asthma attacks. And the important thing to realize is, I think, is that these do not necessarily run in parallel. And I'll just show you some evidence for that. Just a little bit about the word asthma attacks. In the BTS sign guidelines, we switched over to using the idea of asthma attacks. That was partly informed by what the patients said, in that these are significant events, and to call them just exacerbations or flare-ups in a way underplays the importance of them, both for the patients and for in the management of their asthma. So I'll try and talk about asthma attacks as we're going through. This is a slide looking at asthma attack risk in the UK population. It's a very large study. There's something like 100,000 children that were included within it, and it's a database study. Firstly, it shows the occurrence of attacks per year at different age groups along here. And you can see that, especially in young children, attacks are very common. They get less common in the 5 to 17 year age group, and then more common as you go older. And the second graph, just concentrate on the top line here, because that's looking at children 0 to 5, well, these two things here. And what we're looking at is your BTS step, that's what medication you're using, and the occurrence of asthma attacks. Now, as your step gets, as your asthma gets more severe, if we can go back, as your asthma gets more severe, you're more likely to get attacks. But notice that even people who have got well-controlled asthma can have asthma attacks. This is an adult study, and I think it's one of probably the most important studies over the last 20 years in asthma. And this was Ian Pavord's group in Leicester looking at asthma exacerbations. And they divided a group of patients, about 70 patients, into two groups. And they managed one based on a titration of sputum eosinophils. So they increased the treatment if there was more sputum eosinophils and decreased it if there was less sputum eosinophils, irrespective of how they were symptomatically. And a second group was managed more conventionally in terms of their symptoms and lung function using the BTS step algorithms. It was all specified before. And what they showed was that there was a decrease in exacerbations when they based their treatment on the sputum eosinophils, but it didn't affect symptoms or beta agonist use or peak flow variability or the FeNO. So they had managed to pull apart, if you like, chronic asthma features and the sort of tools you would use to look at them from acute asthma attacks. And that's a really important observation, I think, to bear in mind as we go forward. And this was then followed up by the mepolizumab study, the DREAM study, which again is a very important study. I think this is an IL-5 blocker that you'll know about, which targets those with severe eosinophilic asthma. And if you get the treatment, what you get is a reduction in asthma attacks. What you don't get is any real effect on FEV1 or on your asthma control or on your quality of life. So again, what we're doing is they're pulling apart an outcome of a change in asthma attacks from other features of asthma control. And I would summarize, or Ian Pavord summarized this, and I've just pulled this from this paper. So we've got persistent type 2 inflammation is more closely associated with a short and long-term response to inhaled corticosteroids. It is, if you like, a treatable trait. The main clinical consequences of this persistent eosinophilia in patients already treated with an inhaled corticosteroid is an increased risk of attacks. And we have some biomarkers that help us look at this. Now, if you translate this into pediatric practice, actually we don't have a great deal of evidence so far, and we're extrapolating from adult studies. I'd have said in defense, at least most of the problematic asthma I see is often in the older age of children, It's probably, and there are usually some overlap in the studies, although there's never very many adolescents included. So GINA, I think, is quite helpful in what to do about the severe asthma phenotype once you've got there. They suggest that what we do is try and phenotype the patient based on type 2 inflammation. So we're looking for blood eosinophils greater than 150, a pheno greater than 20 parts per million. I think most people will not have access easily to sputum eosinophils. We're looking for evidence of an allergen-driven asthma. And you certainly need to repeat the blood eosinophils on a few occasions. I think if you're on steroids, clearly that tends to take your blood eosinophils down. So you may need it to do it a few times until you convince yourself that it is actually raised. And then they suggest that you can choose out of commonly two biological approaches. The first is an anti-IgE approach, where you would need a sensitization to aeroallergens, a raised serum IgE, and remember there's a window of IgE and weight which you need to get to be within the dosage range, and a history of exacerbations in the last year. And if for the anti-L5 people, you're looking at blood eosinophils above a particular level and evidence of exacerbations. And I'm going to start with omalizumab because that was the first drug to become available. This is a paper summarizing the early experience with it in adults, and I just put it in to highlight to you that the outcome that they looked at was the rate of asthma exacerbations, asthma attacks, and the total rate of emergency visits. So as we've discussed before, this is a drug targeting acute asthma attacks. In the UK, the drug was approved for use in 2013 for people older than 6 years of age who needed continuous or frequent treatment with oral corticosteroids, so really within the ERS definition. And I think one of the most important things that has come out of the use of omalizumab, and I think that's made it a sort of key exemplar of what we do, is that this is a drug that had to be evaluated after 16 weeks. The evaluation that they used for this particular drug was what they called the global effectiveness of treatment efficacy, which was you and the patient sitting down and trying to agree what you thought the patient's control was like. But what we had was a structured assessment. So we've got eligibility for the drug carefully filled in, and then we've got a whole series of parameters that we measure as we go through you getting the drug. So it's a structured drug, and what I'm trying to do when using these drugs is come to an answer at the end of a period of time as to whether the drug has been effective for you or not. If it's not effective, we're not continuing. So here's one of our early patients. He was a 13-year-old boy with severe asthma of long standing, with associated atopic illnesses, eczema, hay fever, and significant food allergies. He was on an exclusion diet and had an EpiPen. He was on high-dose inhaled corticosteroids, montelukast, and cetirizine. In fact, his serotype had been sufficiently high that he had, through that and through a combination of asthma attacks and oral.
So here's a boy who's on omalizumab. We saw that he responded over 16 weeks. It was continued. You can see that over time, we were able to reduce his fluticasone. The secondary adrenal suppression resolved. He got a growth spurt. He'd actually been significantly short, and that had caused him quite significant psychological problems. And we were able to improve that with liaison psychiatry input. And over the long term, he had no exacerbations requiring prednisolone, and his asthma control test was substantially improved. So a very satisfactory outcome from someone who was suffering significant toxic effects from the drugs. And in fact, how do I get to the next slide? This is our experience overall. I've just taken it to January 19, but it's, I think, representative of what we're doing. It's a bit stressful, as you can all imagine. Anyway, here's our experience of omalizumab. So we'd started 49 on it. We had positive and ongoing with treatment was 8. We got some people on it for quite a long time. They were transferred onto adult services, which was very satisfactorily. And we had a number of people where the treatment, they developed reactions. So we did experience some, what we regarded as some allergic reactions, not anaphylaxis, but they led to us stopping the treatment. And we'd also had some non-responders, and we had one girl where it was effective, but she chose to stop. So our overall response rate was about 40%. And if I go to the next slide. This is just to remind me to say to you that one of the benefits that you get of using omalizumab on some people is if you're on oral corticosteroids, then you can often get a reduction on it. And this was David Spencer's experience from Newcastle, published in the archives. He had some children who were in really quite large doses of oral corticosteroids. And you can see he got a dramatic reduction from using omalizumab in the amount of steroids they needed to control their illness. So the question then is, what happens with those people who don't, where omalizumab doesn't work, or who are not eligible for omalizumab? The most common reason is for not being eligible is either you have a very high IgE, or you have a combination of your IgE and weight that puts you out the dosing window. And in those people, we've either started using an IL-5 agent or gone on to use an IL-5 agent. Mepolizumab, again, this is the NICE data, was approved for use in children from 6 years onwards in 2017. We got access to it around a bit later, but we'd been using it before then. And here are some 7 patients who we used mepolizumab on with severe asthma. So the blue period here is the year before they went on mepolizumab, and this is the period, the yellow period of a year. We evaluate it for a year because we're looking at asthma attacks particularly, so a longer period of time was considered required for that. The bars are oral corticosteroid courses, and the red bars are actually admissions to hospital. So you can see this child was having a number of episodes which essentially disappeared when we put them on mepolizumab. Same sort of effect here and here, and probably in these 2 patients as well. But here's 2 patients actually where we didn't get significant improvement. Here's some of the measures. So I think our experience is exactly like the DREAM study in adults. So if you use mepolizumab, it takes the eosinophils, your blood eosinophils, down to a very low level. We didn't think it made a difference to our overall asthma control test score, nor to the FEV1, nor to the quality of life. That was really essentially similar to the DREAM study. And they didn't put the data very clearly in the DREAM study, but it is there. We also looked at FeNO, and we didn't find a significant change in FeNO using mepolizumab. And our experience with mepolizumab is roughly this. That is, we've got a number who've had a positive response and who've got are ongoing with treatment. We had a number where it didn't work, or where we thought there were reactions and we stopped the drug. And we got a higher rate of response overall. I would have said that the omalizumab response of 40% is probably worse than many people, but we've never seen it like this, the 80% that David Spencer in Newcastle reported. For us, it has been more like about 50% response. So the response in mepolizumab has been slightly better. But what happens again if you fail, if you've had omalizumab and you've then had mepolizumab, what do you do next? Well, here's the guidance from Gina. Clearly, you go back and check a variety of things. So are the basics correct? You might want to do a CT scan if you hadn't done one. You're reassessing the phenotype. I think if you were an adult patient, you would consider an add-on macrolide. You may have to resort to using oral corticosteroids. You might already have done a bronchoscopy in these patients. If you're an adult, again, you might think of bronchial thermoplasties. And the general message is you would always continue with inhaled corticosteroids. But I think it's interesting if you look at the drugs available that we've got. So just now we've been thinking about drugs that are targeting the Th2 pathway. We've got omalizumab, so we've got people that have failed using that. We've got mepolizumab, people that have failed using that. Reslizumab has not been found to be effective in children, and it's given intravenously. I noticed that some of you are already using benralizumab. We've not used that because in my judgment, if you'd failed in one IL-5 blocker, I couldn't really see the rationale for going on and using a second IL-5 blocker. So I thought that if I was going to use an alternative pathway drug, then I should really be moving on to thinking about using dupilumab as my sort of third line drug. And that's what we've done in a few patients. So dupilumab, it blocks the IL-4, IL-13 thing and interferes with eosinophil migration. And notice its main effect is going to be on exacerbations. Surprisingly, it does give you some improvement, usually in FEV1, that's been reported. And I think very interestingly, it brings about a reduction in FeNO, because FeNO comes down if you block the IL-13 pathway. It doesn't seem to be related to the IL-5 pathway. So the fact that we didn't get any response when we used mepolizumab and they didn't get any response in the DREAM study, I think it's exactly what you would expect, because you need to block the IL-13 pathway if you want to see an effect in FeNO. Here's the data from the New England Journal of Medicine paper just to show you. So the primary endpoint they used was attacks, and they got a significant reduction. They did find a small increment in lung function sustained over the period of time that they used the drug, and a fall in FeNO compared to the placebo group. And here's, we've used it in 2 patients, and we've got some patients in the wings where we're about to start it. So again, here's a girl that's been on omalizumab, failed, been on mepolizumab, failed, continued to on oral daily corticosteroids, still having attacks, and this is her moving on to trying dupilumab. And you can see she's on moderately high doses of oral corticosteroids. So she has no attacks during the period of evaluation. We gradually were able to wean her steroid down. You can see that her FeNO has fallen from about 60 quite quickly down to more normal values. Her asthma control test substantially improved, although we weren't expecting that, and her quality of life also got better. Interestingly, about 4% or 4 or 5% of patients who dupilumab is used on get a significant eosinophilia, which seems incredibly surprising, since you'd have thought if eosinophils are important, you wouldn't expect them to go up, yet asthma control to improve. And you can see that our eosinophil levels were a relatively low level. They had been higher on occasions, and they've gone up substantially with this drug. But we've continued to use it on her. She's had an extremely good response. We've been able to stop her oral corticosteroids for the first time in years. Her asthma is well controlled, and we've been able to reduce her high-dose inhaled corticosteroid medications a little. Just to give you a little bit, this is from an adult slide set I saw, but I think it summarizes my experience pretty well. I don't have any experience of benralizumab or reslizumab, but omalizumab, we did see these sort of features that we were concerned. We were seeing some allergic type reactions that led us to stop using the medication. For mepolizumab, I think the main thing we've seen is injection site reactions rather than other problems. We haven't seen any conjunctivitis or blepharitis in the small number of patients we've used dupilumab on, but we have seen the eosinophilia. And not surprisingly, they looked at it in the COVID area. I think people are a bit reluctant to use omalizumab in a home care setting, but these other drugs are becoming available in preparations which you can self-inject and get, or the patient can self-inject and use at home. So it's just interesting to think about the biomarkers and what they tell us. So we've got the peripheral blood eosinophils, which clearly reflect, which are thought to reflect the airway and systemic IL-5 inflammation. And it's clear that anti-IL-5 drugs, particularly mepolizumab, takes these down to very low levels. So if you're getting a response, your eosinophils should be going down to 0. And that's not the case in dupilumab. And as I say, we've had examples of this small group of people who seem to get an eosinophilia with the drug as opposed to not. Interestingly, Pheno reflects IL-13 airway activity, which I think is extremely interesting, and it's reduced by dupilumab and anti-IL-13 drugs. Now, I think these things are really important because I think it's telling us that there are indeed different endotypes of asthma, which can be affected by different drugs. So it's like electrical circuits to my mind, and what you're doing here is you're pulling out the IL-5 fuse, and here you're pulling out the IL-13 fuse. And clearly, if you pull out the right fuse in the right patient, then you get a significant effect. At least that's what it seemed like to me. So where have we got to so far? I would have said, as predicted from the adult work and from the initial work in the drugs, what you get with these drugs is generally a significant reduction in asthma attacks. You will get benefits, I think, because if you're not getting asthma attacks, you're not taking courses of oral prednisolone, and so that brings about benefits. You're not in hospital potentially. But it's attacks that they seem to be working on particularly. And often, if you've got patients on systemic corticosteroids, you should be looking to significantly reduce the systemic corticosteroids, possibly to 0. But the effects on other biomarkers, lung asthma control, lung function, etc., may be dependent on the particular signal pathway that you're targeting. I would have said too, it's interesting when you start using these drugs, if you get a patient who responds to them, what you find is really striking because it will take out attacks, you'll be able to reduce their medication. They think it is almost miraculous considering that you're dealing with a population of people who've had significant therapies, significant consequences from their asthma, significant limitations imposed by it. So if it works for you, it's a really spectacular response. What we need now, I think, is we have very little pediatric evidence. We don't have comparative studies. We have little guidance about which drug to start with and when to switch. You've heard basically, I've started with the one available, switched to another one, and then switched to one which seemed to me to be logical because it looked at a different pathway. I have no idea whether that's a strategy that we should be using overall. There may be other strategies, for example, combining the drugs. Maybe you need to combine an IL-5 blocker with an IL-4 13 blocker. We don't know at present. And so clearly we've got much work to clarify what the most effective strategy is. So that's where I think we've got to, or where I've got to so far in using these drugs. I think the one thing you can predict is for children with severe asthma, the next 5 to 10 years are going to be significantly different as we work our way through how best to use these new tools. But the prospects, I think, are very bright once we understand how to do it better. Thank you very much.
Thank you. Thank you very much, Jimmy. That was an excellent review of the state of the art. It's, I think, very good to get a really practical view of these medications in real life as opposed to just in the trials. There's a few questions which I'd like to put to you. One is from Andres, and it's the same question that I wanted to ask you. No, in pediatrics, we have a duty of care to our children, and if they're non-adherent, I have actually started for example, in chaotic households, children on Xolair at a sort of much lower threshold than I would have normally done in terms of control. I'm pretty sure that if they'd taken their directly observed their ICS, their control would be much better, but I just didn't want them to have a life-threatening event. Is that a reasonable approach, or is it pragmatic, or are we just not chasing the issues effectively enough?
Well, I think it's probably pragmatic for some people. I suppose we were a little scarred back in the days when we were following your approach, Jonathan, of using depot and steroids as a way to judge whether people were steroid responsive. And we did finish up with some patients who were getting injectable treatments, who liked the injectable treatments, where it improved their asthma control. But since it was a depot steroid, it wiped out their adrenal function for years afterwards. So I think it's a pragmatic response. I think I think as the tools become better, I mean, we've just started using compliance monitoring, and I've got this idea that routines are really important. And so I'm thinking that we will routinely deviate people into a clinic where we try and establish, are you taking the medication appropriately? And can we help you devise strategies? It may be once a day treatment, or some strategies that allow you to deal with the issues that you're dealing with. First of all, to be able to, rather than to go on to injectable treatments with the various issues that arises with them. But, I think you are where you are. And if an injectable treatment, if you like, a directly observed treatment gets you out of the hole that you're in and controls a person's asthma while you sort out other things, that might be quite a good thing to do.
Okay. One question is, and we're now seeing, I saw a lad in clinic who was, he's 18 next month. He'd been on Xolair for, it must be 5 years or something like that. And I'm handing him over to the adults. So the question really is, I mean, this is from Abhinav. How long can we use these medications? Is this potentially lifelong, or do they need to be stopped for a bit to see if they're effective?
Well, I don't think we have a clear answer to that. I suppose when we started using them, we did expect that they would be lifelong. The approach we took following the adults in Glasgow for omalizumab was that we were expecting that we would give it for 5 years and then try and stop the drug and evaluate roughly where we were. Now, if you start with, many of these children are into adolescence. If you start with 5 years, it's exactly like you say, you're handing them over to the adults. And I can remember one boy we handed over, and the adults discussed it with them, and they decided he would go through university and then he would try stopping the drug. So I don't think we've got information yet that says how long do we need to use them. There's probably going to be a pragmatic period at some point of stopping the drug and seeing if you no longer need it. Clearly, if you've got very well controlled asthma and you're down to using, low dose inhaled corticosteroid and an injectable therapy, you're thinking, do you really need to continue with this? And I suppose the fundamental issue is, are these drugs potentially disease modifying? Are you able to turn off pathways in a way which in the long term modulates them down to a much lower level, and which more conventional asthma therapy potentially can control what you're doing? And we don't know the answer to that yet. That's clearly one of the important issues that we need to work out in the next few years.
Okay. A question just from Mary. I think I know the answer. Cost of the medication is presumably not an issue once it's approved by your relatives, the Scottish agency?
And we've been very lucky, and I've used a lot of these medications off-label. So I've extracted the limited data in adolescents and said, well, okay, there's some experience in using this drug, and my local hospital has supported me in paying for the drug. I think that when we looked at omalizumab, overall, it wasn't particularly expensive. And when you're particularly attacking asthma attacks, you don't need too many asthma attacks with people in hospital for a number of days for basically you to cover all the costs that you can think about. So I don't think it's going to be a huge issue for what, particularly since it potentially stops people coming in, troublesome people having more significant attacks that are definitely expensive to deal with.
You mentioned about assessing effectiveness, and you talked about 16 weeks. Isabel has a question. I mean, is that the correct length of time? Could some?
I don't think we know that. I mean, for omalizumab, they use 16 weeks. I suppose for the other drugs, we've said we'll certainly evaluate you at 16 weeks. But since the main outcome is the attacks, for mepolizumab, we've generally gone for a year. So if it's clearly disastrous at 16 weeks and it's not working, it's probably, I think, reasonable to bail out. But is it a fair trial to say it's been effective? I think you probably, for mepolizumab, if you follow what's available, you're probably going for a longer period of time. And I suspect the same is probably true for dupilumab, because the outcome you're using is not that common. But again, maybe in 3 or 4 years, we'll know better that actually, yes, you can evaluate at a shorter period of time and predict the people. I mean, the trouble just now is it looks as though I would have said from the effects of mepolizumab on eosinophils and the effects of dupilumab on the pheno pathway, there are clearly different pathways which are important. Yeah. And the trouble is we cannot yet predict which fuse we need to pull out to fix or to improve your asthma. Once we can do that, then we're going to be in a much better position to be able to move forward.
Yes, I mean, this pulling out fuses reminds me of 2001: A Space Odyssey, which I remember. Okay.
Well, let's hope Hal takes over and does it all for us.
Marielle, who of course we know, she just wanted to clarify. You start with MEPO and switch to Dupi, dupilumab.
Well, at present, dupilumab, mepolizumab is now available for us for 6 to 18. We haven't. Dupilumab is just, if you like, coming onto the market, so I have to use it off-label. I think most of the work has been targeted at the IL-5 pathways, so it seems logical to use those first of all. It's easy to monitor eosinophils and things like that, and most of these people are going to be atopic with a raised IgE, with evidence of eosinophilia, so it looks as, and with attacks, so they look as though they tick the boxes for an IL-5 pathway blocker. But whether that's the right strategy or not, I don't know yet.
Yeah, I mean, there was Kappa asked exactly that. What about the Th1 endotype? If you have Th1 and high pheno, would dupilumab be something you would consider?
Well, I think you have to be careful. The Th1 phenotype I take to be a sort of neutrophil type pathway, and actually that's a completely different set of asthmas, we think. And in adults, they're obviously trying to work out what to do there. And I'm not, these Th2 drugs, I'm not sure they're going to be relevant in a Th1 setting sort of thing. So if you like, we need much more information about what we're doing.
Yes, I think so. I mean, one question Andreas asked about adherence. I think one question that combines with me is, we do still see children on, for example, Xolair, who have moderate levels of symptoms or sort of much better than they were, but not perfect. Do you think that the adherence changes once a child is on a directly observed injection therapy? Is this something that we should continue to follow and be careful about?
Well, I think so I can't give you a proper answer to that just now, but I think probably going forward, if you've got a situation where you've got a lot of benefit from the drug, but you've still got some symptoms and you're worried about adherence, I think in the future we'll be back to monitoring it to establish that you are taking the drug appropriately. And then there might be strategies which are more appropriate, if you like, in a sort of partially controlled. So maybe once a day strategy using something like Relvar might be a good approach for that. But I think getting the information will become more relevant once we're into the habit of saying, well, let's think about your adherence. How's it affecting the drug that you're on, sort of thing.
Yeah. Just a straightforward question about the blood eosinophil count. Do you use the adult criteria of greater than 300? This is from...
Yes, I mean, in fact, I think for most children, it's not too difficult to find any with asthma. It's not too difficult to find one eosinophil count more than 300. That's my experience. You'd certainly easily find one more than 150, sort of thing. I mean, I think it would be worrying if you didn't find one somewhere that was really suggested that, you know, that they had a sort of allergic type asthma.
And in terms of what you do you sometimes sort of reduce the frequency to, you know, from 2 to 4 weekly? Do you alter that?
I've adjusted the frequency occasionally in people, but often it's, and so I can't say that I've reduced it, what's the word, down the way. I've had occasional people, particularly with omalizumab, who've come along, they've been on 4 weekly omalizumab, and they said in the 4th week, they find their asthma becomes more of a struggle. So I've had some people where I've moved from 4 weekly to 3 weekly, but I don't know whether it's sensible in the longer term. If you're on 4 weekly, can you make it 6 weekly or 8 weekly? I don't think we know the answer to that yet.
And both Marielle and Errol have asked the same question, MIPO and dupilumab or some combination, or is it that we are looking for blockers much further sort of earlier in the inflammatory pathway, which will sort of stop us worrying about all of that thing?
Well, I suppose the worry is, so I think, yes, it seems very sensible to me that there may be a place for combining the therapies. I agree with you that actually the logical way to do that might be to move the therapy back the way and have a more extensive blocker early in the pathway. And I think there's some really interesting work, which I don't fully know about, going on in dermatology when they're using some of the JAK-STAT inhibitors, which are oral and can be and block earlier in the pathway. But it looks as though those are more immunosuppressive drugs. So I'm hearing they're seeing some side effects like, you know, fungal infections and things like that. So it's probably a group of children who've got some immune abnormality. You put in a drug and actually you're looking at a more powerful blocker and you get more side effects. So my worry is the more you block, when we don't really know what we're doing, actually, hold on a minute, are we starting to block things that maybe are important in other ways? So that's something that we'll need to watch, I think, as we go forward.
We've got time for a couple more questions. Visti asked, I mean, small airway function became a very hot topic at one stage, and maybe it still is, I don't know. Now, what is the effect of these on you know, measures of small airway function?
Well, if he means things like the lung clearance and things like that, I can't answer that specifically. I think clearly if you use flow volume derived parameters, and you can see some people their lung function is improved. And I think the results with dupilumab are particularly interesting because the prospect that you get a systemic increase in your lung function with the drugs and not just an effect on asthma attacks, I think it's very it'll be mechanistically important, I think, useful to understand, because I think it looks as though, you know, there's clearly a group of children which people will see who as a consequence of childhood asthma finish up with significantly reduced lung function at the end of their time. Not all of them, but some of them do. And if we've potentially got a drug that can push up your lung function, and maybe using that early in life, maybe we'll be able to ameliorate some of the side effects. But again, I think these are things that are going to need to be tested over time.
There were two questions related to reactions. You mentioned reactions. It's something that I actually have not seen in my patients, but I don't have as many treated as you. And by the way, I don't use intramuscular triamcinolone anymore. That's
yes, we stopped as well.
we only advocated it for 1 or 2 doses, not for.
Well, it was very effective, Jonathan. It was interesting because it was a directly observed therapy, but the side effects were quite horrendous.
Yes, well, you didn't mention lipodystrophy, which also was an issue. Yeah, so that's remove that. But yeah, reactions are these. sort of mild allergic reactions which may have panned out?
In general, yes. I mean, we haven't had any anaphylactic reactions. So, but we did have some, particularly with the omalizumab. It's interesting. Mepolizumab seems to me to be a very safe drug from that point of view. So we get some local reactions, but nothing much more than that. And that's pretty much what I get from the literature as well. I wonder whether mepolizumab is actually interfering with one of the allergic pathways. So almost it's, if you like, it's the drug itself is preventing you getting significant allergic problems. But omalizumab, we did think caused problems, and it did lead us to stop some people using it. Occasionally, we got children that were quite tired on the day they got it as well, although that probably gets better as they go on. Dupilumab, I think we'll need to watch out for because of these skin side effects and conjunctivitis that the dermatologists actually notice more. Again, maybe it's more of a feature in dermatological patients. I don't know yet.
Okay, well, I think we have to draw this to a close, but I mean, I think there are many other questions, and it's clearly there's a whole range of issues that still need to be explored. So more grist for the mill for academics. I would advocate, perhaps you might agree, that we need a much more coordinated approach as a community to this, and identify the key studies that we want to do.
Exactly, absolutely. We made it. It's a bit black box just now. We potentially get very effective therapies, but we need to know how are they used in children? What are the problems we do? When do we need to use them, etc., etc., etc. Much more research needed.
Yes. Well, thanks very much, Jimmy. This, I think this is being recorded for YouTube, so it should be available, and certainly will be available for ERS members to access as well. I'd like to thank you again, Jimmy, for that excellent talk. I'd like to also thank Ali Merzouk for organizing this and overcoming the technical issues which seem to affect these sort of things. But I think we saw all your slides, and we had time for discussion. So thank you very much. So I'm drawing this to a close. So thank you very much, everybody, for coming and listening. Please come to the next ERS. I hope it's going to be face-to-face. Please support the Pediatric Assembly if you haven't assigned yourself to that. And if you're thinking about biologics, have a look at the ERS website. There is a ERS CRC called SPACE, which is trying to coordinate information about biologics across Europe, and you can contact the members of SPACE that are on that website. So thank you again, and goodbye.
Thank you, Jimmy. Thank you, Jonathan. Bye-bye.